Hi, this is Jamie Hadfield with Legends Health, Wellness, and Performance, and today's guest is Diane Young. She has been in healthcare for 18 years. She's been a nurse practitioner for 5 years. She started out her career path in ADD and addiction recovery, and then she's now moved from conventional medicine over to functional medicine. And it was really interesting the other day when I was speaking with her, she said, Jamie, she's like, once you study functional medicine, she's like, you can't go back to conventional medicine. And today she's here to specifically talk to us about what else can you do besides meds for mental health. Welcome, Diane.
Thank you.
So what is functional medicine?
Well, I actually prefer the term integrative medicine.
Okay.
Because we add, the best of both worlds, we hope. We add more into the conventional medicine system than is currently being utilized. Functional medicine is interesting. There are strange websites out there saying it's pseudoscience, or I think on Wikipedia they did talk about it being quackery. It was interesting, I read that entire page. It was targeted directly at IFM, Mark Hyman, anti-vaxxers. I'm not an anti-vaxxer, but it was interesting. It was so specific, and the articles they drug into it, I just wonder who wrote that article. I don't see an author. So, and in academia, we never use Wikipedia. It is not considered to be completely true or valid. There's a lot of fallacious statements on Wikipedia, so we have to be careful what we take as a definition. I know it's a free dictionary or free encyclopedia, but there's a lot more to functional medicine. It was, the term was coined because we were looking more at disease and getting more to the cause or root of the disease instead of symptom management, and to definitely help with the function of the body. So it's very misleading the way they state it.
My understanding of that is it really is a systems biology approach. So you're looking at all of the systems and how the systems function together, because conventional medicine went down this path of you're a neurologist, you're an endocrinologist, and we're not necessarily putting all of the body and looking at the body systematically, because we became so specialized, we're forgetting to look at the rest of the body. Is that inaccurate?
Exactly. I mean, it's very, very specialized. It is the biggest deficit we have right now in medicine is primary care. So everything is so specialized that we forget that maybe there is something else attached to the arm that's having a dysfunction or has a disease state. And how many systems are playing into the disease process, definitely. If we do look at symptom management or at just focusing on one area of the body, we miss a huge contributory process going on. Alzheimer's is a classic example of trying to specialize in just the neurons of the brain, when the inflammatory processes and the other things going on are multifactorial. I love Bredson's comment, trying to, it's like having a house with 85 holes in the roof and you've got one bucket under one hole and hoping not to flood. It's not going to work. It is multifactorial, and that's why it's been so hard to pin down some of these diseases and find a magic bullet or a perfect system, a one-prong approach. It will not be a single treatment that's going to fix such a complex disease, and mental health is that way. It's incredibly complex. We've tried to mechanize it into, serotonin, norepinephrine, epinephrine, dopamine, GABA, all of those neurotransmitters. We've tried to pin it to one neurotransmitter being off, but it's never been that way. And because there's so many variants, so many different presentations, I find that we can't use a single approach. We wish we could. I would love to take one medication and say, oh, my hypertension is fixed, my mental health is fixed, my whole life is good. But it isn't going to be that way. And I even Hippocrates said, know the person you're treating more than the disease that you're treating them for. I mean, you need to know the context of what's going on as well.
So in mental health, I mean, the topic today is how do we avoid medications, or not necessarily avoid medications, but how can we use less medications to help the disease process, especially in mental health? Because I think in mental health, we always get thrown a pill. What are other avenues that we could take?
Well, and psychoanalytics, cognitive therapies, they've been around as well. It's almost like when the first medications came out that were, Thorazine was obviously first, which is interesting that it was being studied in malaria when they noticed, this creates kind of a lobotomized effect on people. It calms them down, they become sedate, we can control them. And especially in a psychiatric break or a person that's of harm to themselves or someone else, you want to have something that helps them, and we don't want to restrain people and lock them in padded cells. So they were very interested in that. But again, the lobotomy procedure itself is barbaric to me, and it has been. And yet it went on for many, many years. Thousands of people lobotomized. There is psychiatric illness in this world. It is pretty ubiquitous. I mean, it's through every culture, through everywhere in the world. There are some people who are dealing with psychiatric illness. I'm not discounting that. A new book that came out, well, it's not so new, but Alan Francis, he is one of the authors of the DSM-4, and he was a chair in the DSM-5, so he's a psychiatrist. And he has a book out called Saving Normal, which is very interesting. I mean, how many people are being treated for mental illness that may not have a true mental illness? They may be going through a terrible life situation. They may have grief. They may have trouble with coping skills. But are we deeming them as psychiatric patients?
But isn't that normal to go through some type of that through?
It's absolutely normal.
In life,
Yes.
in your lifespan, there's going to be some time in your life that you're going to feel depressed.
Absolutely.
Or anxious.
And anxiety is a whole beast of its own. But I am thinking we need to take a little step back and not overdiagnose people as well. There are people who need psychiatric assistance, and it is a chasm deficit. We do not have enough providers to deal with people who have true psychiatric illness, yet we're flooded with people who feel like they have psychiatric illness, due to the DSM-5. I mean, it cast a broad umbrella. It's very, very sad. I think I got one module or one, 3-month stint in my training in mental health, and it wasn't as deep as I would have cared for. So I've had to do a lot of study on my own. Countless hours of study on mental illness and psychiatric disorders. Again, most people do not have a true psychiatric disorder. And in Dr. Francis's book, he said, he made a statement that kind of got me. Pharmaceutical companies were licking their chops for this new broad amount of patients that were going to be coming through the doors with psychiatric disorders, be it binge eating disorder, generalized anxiety disorders, obsessive compulsive. I mean, we all
have
post-traumatic. I mean, there definitely is a post-traumatic disorder, absolutely. But we have to be very, very careful in diagnosing these things. Primary care is 90% of the prescribing going on for people with psychiatric disorders, or what we consider psychiatric disorders. There's such a worry and concern. Are we getting involved soon enough? Are we preventing suicide?
I want to back up a little bit. 90%
of the medications given out
by
through primary care. And I would say OBGYN is pretty high because you have the postpartum depression. That is a real thing. That is absolutely real. And I don't want to discount that people have mental illness. I'm just saying, what is the cause? Dr. Walsh, in his book, Nutrients, it's a nutrient, treating disorders with nutrients, nutrient power. Yeah, Dr. William Walsh talks about it. He's a psychologist who has studied, he's done a lot of forensic studies a lot of scientific basis for his theories. He actually talks about copper overload in females because we get high in copper right before we deliver the baby. And copper has a major role in dopamine synthesis. So some women have difficulty offloading that, and copper and zinc have a very, very tender balance. Copper is 10 times transported to 1 time of zinc. I mean,
wow.
we need, in a supplement, someone who is very adept in them knows you need 10 to 1, 10 zinc to 1 copper, because they share the same transport system. So there are certain biologies or people who are struggling with some chemical imbalances. But definitely knowing what those are and helping, I mean, the treatment for that basically is helping them to offload the copper and increase the zinc for the dopamine balance. So,
How do you do that? Is that chelation?
No, it's a
what is
nutritive
that?
approach. It's very nutritional approach, but also knowing people's genetics are going to make a difference. I'm not a big fan of just doing a giant genetic panel, and the panels that are available are, let's do a genetic panel, let's look at these SNPs, these single nucleotide polymorphisms, and then say, oh, you would respond to this drug, or you might respond to this drug based on correlation. Again, it's almost sickening that it's all to drug. Like, I'm going to tell you what drugs you can metabolize, what drugs you might be able to have response to based on your genetic profile. So that's saying, basically, the only treatment option you have is a drug, which is far from the truth.
Well, but isn't the genetic profile supposed to help with nutrition, to figure out nutritionally what you should take as well? Because I know there is like a genomics nutrition test out there.
Right, there are, yes. And I mean, what it's basically saying is you're upregulated or downregulated in the ability to express a protein or break down a protein, or whether that protein or that specific molecule will help balance another. I find it interesting in genetics that we have an upregulation in one pathway and a downregulation in another pathway, so the body's pretty adept at balancing itself over and over. The risk we find with just saying, here's a supplement, this is going to fix your disorder, is that's not necessarily what their problem is. You have to take into account there's several other genetic pathways involved in that one system, and the body's so adept. If the primary system is broken down, it will have a secondary and a tertiary pathway. If it has to create a molecular balance, it does it. But there are instances of toxic overloads, people having difficulty. Methylation is big out there right now. Dr. Ben Lynch is probably the foremost expert in studying methylation, which is part of the detox pathway, and it works with getting rid of some of the toxins as well as neurotranscription. So you can't just treat someone and say, oh, you have a methylation disorder, I'm going to give you these vitamins, these supplements, and you're going to be perfect.
Well, I think functional medicine actually gets the image of functional medicine is, well, they're just trading a pharmaceutical drug for a nutritional supplement.
Yeah, I don't believe that's true. I love the blend of the both worlds. I would say the predominant study is done in pharmacology. They have the money to do the studies. Prime example is Imitrex or sumatriptan used for migraine headaches. So there is a study in the National Institutes of Health, and they used powdered ginger versus Imitrex. I mean, powdered ginger, of all interesting things, which has been prized as a medicinal value as an herb or a botanical for centuries and centuries. But who knew that it did much for us, comparing it to a drug? But they did a double, I don't know how you do a double blind, whether it was capsulated or what, but they did do a study with 2 groups, and they treated one with a teaspoon of powdered ginger and one with sumatriptan, which is an Imitrex. No difference, no statistical difference in relief of symptoms, no statistical difference in whether they wanted to change modalities. I mean, people that were using sumatriptan were happy with that. People using the ginger were happy with that. No statistical difference at all, which is kind of validating, except ginger costs 5 cents and sumatriptan is $100 for a prescription, or more.
Wow.
But there really isn't enough money involved in who's going to be your powdered ginger manufacturer and do a $20,000 study or $20 million study for this. But it's still out there. It's still an option for people who are struggling with migraines that maybe don't want the after effects. Sumatriptan has pretty significant side effects. Most of my patients tell me after they've had that, they are wiped out. It drops their blood pressure. It's a big change to the body. And I love pharmaceutical because they create a great response. I mean, it's a profound response. But anything that comes with a profound response usually comes with a profound side effect or reaction. You create an action, you get a reaction. It just...
And that's with pharmaceuticals or any nutritional supplement. There's a response for eating
there's a
green
response.
Beans. There's a, right?
Well, the beauty of the nutritional supplements is many times they have other chemicals in them that balance side effects as well. I mean, it's a little less pronounced. I can use L-theanine, say, which is an amino acid for anxiety. And it does help. It helps with the GABA system, and it's interesting because it upregulates a little bit, downregulates. It's helpful for focus, but also it brings down the anxiety response. Now, someone who's had alprazolam or a benzodiazepine is not going to find L-theanine working great for them because they're used to a pronounced response. Pronounced to the point where it can cause death over sedation, especially mixed with other medications.
Okay, for the general public,
Oh,
what is dopamine? What is GABA? What does that mean
so
to the
in
public?
neurochemistry, we have some major players in neurochemistry. One would be serotonin, which is what is mostly targeted with the medications, the safest way we've found. Serotonin can cause feelings of well-being, comfort. It's not an upregulating.
It's a happy.
It's a very happy kind of, I would say, relaxed situation. Serotonin, though, when it's too high or too low, can cause symptoms of anxiety or depression, high or low. And they've had a very hard time quantifying what's the exact level of serotonin for people. But they have found when they give them a serotonin reuptake inhibitor that it tends to, increase well-being to some degree. Now, dopamine would be more in your pathway of joy. It's an activating hormone, neurochemical. So dopamine was vilified in schizophrenia and other, psychotic breaks. They thought it was more of a dopamine pathway. But we're finding that really it's the balance of those neurochemicals, not just one thing. Because if you don't have any dopamine, you also have problems with focus and joy. And the dopamine, the ability to balance dopamine is so important, especially with substance use and addiction. So that's that dopamine pathway that brings joy or reinforcement to something. So we like that effect.
Yeah,
so
yeah.
we want to continue that. And dopamine is highly variable in people, but also personality. I mean, the balance of melatonin, serotonin, melatonin is downstream of serotonin, so hence the sleep disorders with depression. And dopamine, excitatory, the addictive personalities, the more talkative. I would say I'm a high dopamine person.
Okay.
And I find joy in simple things, and I'm not necessarily depressed.
Now, is that because of your genetics?
It could be partly because of my genetics. Also, I haven't done my entire panel. I don't have a severe methylation defect. My son does, and my husband does. So they deal more with the depression, and that's not just because of the methylation. There are other issues going on. But so then you've got GABA, and the GABA system is your relaxing. That's the system that those receptors are what pick up alcohol and sedatives, and we do use a lot of gabapentin. People will use Neurontin, but it's such a huge dose compared to what the brain is used to. So we're giving people some things that cause an imbalance downstream. I think...
So how do we prevent that so they don't have the downstream effects?
Well, that's kind of difficult. If you look in the pharmacology of these medications, say bupropion, which is an atypical antidepressant, which I do use in clinical practice quite frequently, especially with people who are dealing with addiction and who have a very flattened dopamine response. Bupropion, it will say mechanism of action unknown. And it will say that in a lot of the serotonin reuptake. I mean, there are so many medications where you're looking for
using them.
Yeah, what's the mechanism of action? How do I use this safely? And it will say unknown, not quite known. You know, we think, we hypothesize, but we really don't know entirely what things go on with these medications. We have a lot of study. We've spent billions of dollars, thank goodness, on it. But some people do have a poor response to the addition of medications because there is a side effect. Serotonin reuptake inhibitors, they are known to lower libido and sex drive. I mean, for some people flatten it completely, which is difficult for some relationships.
Well, I think that is part of health.
That is part of health. I mean, you need to look at the mind, body, spirit, and relationships are very, very important to humans. We are highly evolved in that area with relationships and sociology, and it's part of the joy of living.
It is.
So we don't want to impair relationships. I'm not saying not to take an SSRI because you don't want to have that side effect. And for some people, it doesn't cause that side effect. For a majority, it does. What we have found also, I spent probably 2 hours looking up suicidality and SSRIs, and it's just all over the place. You can't pin it down. It's so multifactorial. And I do believe that probably underreported how many people are thinking of suicide or attempting suicide, because most of the studies have been retroactive. So they're looking at other studies, Cochrane reviews, which is the gold standard for looking at the science-based study.
I know I've heard they're looking at ketamine and glutamate pathways for suicide ideation. Can you speak to that?
They are in the early stages of looking at that. Some of the anecdotal or small studies have been very favorable to that ketamine treatment. It's a very low, amount of ketamine given over. It's usually given IV. It's somewhat expensive, $400 to $500 for a treatment, but the response has been incredible and amazing for some people, for quite a few people, and their suicidality just completely goes away. Like, it's gone for weeks at a time, amazing. Which is amazing. Where suicide with SSRI, even in the UK, they said they want the black box on it, black box warning, that with adolescents there was a 5-fold increase in risk of suicide within the first month or two of treatment, between the first 4 to 6 weeks, which was interesting to me because it kind of flattened out in adult populations. I don't know if they have a more robust response to that, if their neuroplasticity is still, they have more of a forward and backward swing, just a much more broad or strong swing in serotonin levels, which may during the very, very low may explain some of that they have a lot more risk with using those. So using it cautiously is absolutely critically important. And when you're going into primary care and you're told, it's very safe, give them an SSRI. Everyone can tolerate an SSRI. Yeah. They are correct that the risk of mortality is much lower than with the tricyclic antidepressants and with the MAOIs and with the early antidepressants and antipsychotics. I mean, we went from Thorazine to Haldol to Seroquel now, Geodon. We've got a lot of 3rd and 4th generation, which are a little cleaner drugs. So, but it is interesting that they are moving into the realm of children. That's what probably concerns me the most. Can we take a watch and wait approach with children and with young adults? It's a very difficult time. I mean, hormones play an enormous role in mood and cognition. Enormous. And these children are going in from, prepubescent to adolescent, and these hormonal changes are very difficult. The bullying, the social things, they've never gone away. That's been going on since the dawn of man, that when we go through those critical changes, that's been going on.
So how does environment and how does diet come into play for mental health?
Well, environment, there's a lot of people who say that there's no such thing as toxicity, that heavy metals don't exist. I mean, they exist, but it's rare to have a problem with them. It's the same thing with parasites, you know. Oh, and we don't have parasites in the United States, but we actually do have parasites in the United States. Not as common as in other third world countries. I mean, we have done a lot with environmental health that way. We're not as toxic as China and other places. But it is interesting. I had a young man, a father, sitting next to me at a little gymnastics class my daughter was in, and his little boy was dealing with like an autism spectrum, but he was very highly ADHD. So he thought, oh, maybe this would help, you know, to do the exercise, and it is a very good thing. But it was funny because he was a researcher at the University of Utah studying obsessive compulsive disorder.
Oh.
And when I talked to him, I said, you know, I've used low dose fluoxetine in some of my patients with OCD, and it has worked. It has helped them to some degree. And you know, that's some of the things we're looking at. He goes, that's what we're studying with the rats. We're giving them low dose fluoxetine. And I said, well, how do you tell if a rat has OCD? He says, well, it's excessive grooming. You know, they do all these behaviors. So I find it interesting that we're still studying so much on rats with fluoxetine, because we are. When I looked up fluoxetine recent studies, I wanted some newer studies. It was almost like we weren't studying any humans on it, and yet we've had it forever in humans. We've almost abandoned, oh, it's safe, it's fine to use, we're going to go study rats now. They're studying structural changes in the brain. There are structural changes in the brain after long-term use of fluoxetine. Who's to say whether they're bad or good? There are changes, though, and they're seeing it in the rat brain. And obviously it's easy to study a mammal or something that is on a rapid track. I mean, their life is so shortened. We get to see a snapshot of 10 years use, 50 years use on a human. It would take 10, 15 years to look at, you know, 50 years to see what the long term, but we can look at a rat in 2 or in 1, you know. So I understand that, but what was interesting about this gentleman is he has all this knowledge. He's a scientist, and he says to me about his son, I just don't know what to do. And I said, well, have you tested him for heavy metals or for other things? And he said, yes. They did test him, and he's a little high in lead. And I'm like, a little high in lead? There is no safe level of lead. None. It's a direct neurotoxin. If you are finding lead in serum or in metabolite, there is no safe level of lead.
But how does that affect the mental health?
But what I'm saying is this is a little boy who may have more of a toxic chemistry that may end up in the system, treated with 3rd and 4th generation antipsychotics, Abilify. They're using it in children. I mean, I was shocked to find they were using Remeron in children. These are heavy psychiatric meds that do cause changes in the neural system of the brain. And yet, oh, well, he's a little high in lead. I mean, what are we doing? And with children, I pulled an article of antipsychotics in the crib. And it was written, I think it was written in 2012. It was put in the New York Times. Antipsychotics in the crib was the name of it. And there are many, many doctors who are against that. And they're not, these are good people trying to do the right thing. But then if we have a 2 or 3-year-old because they're having temper tantrums, or what else could be going on? So if we look at nutrition, if we look at the key amino acids, the amino acids that the human body can't make, the essential amino acids, are they getting those? How in the world can you have a little factory, a little cell factory say, I need you to make this protein, but I'm not going to give you this particular ingredient? What's the body to do? Again, there's the second and tertiary pathways, but they're not ideal, and they come with other issues. Inflammation, chemicals in our food, poor nutrition, all are contributing to problems in mental health.
It was what you just said was really interesting with children, but you didn't speak about breastfed versus bottle fed. Does that have an effect on nutrition for the baby?
I think it has a huge effect. There's been a lot of interest right now in the gut microbiome and how its influence over the mental health chemicals, because we make serotonin and dopamine in our gut. We make probably 80 to 90% of serotonin is made in the stomach. And all psychiatric meds will tell you could have a side effect of nausea or sick stomach or appetite changes.
Because of the
Absolutely.
gut right
There's
here.
a lot of difference in the gut too, and also what's going on in the brain. But breastfed versus formulas, I think there's a drastic difference. When a woman is breastfeeding her child, she's also producing predominantly, there's oligosaccharides in that. So there's a form of sugars that are highly digestible. A baby doesn't have any digestive enzymes per se. Everything needs to be kind of pre-digested for them. But those oligosaccharides feed that microbiome, and that they get a good root feeding to those little bugs that are in our gut that make a huge difference in our life. And we're 10 to 1 outdone. We have 10 bacteria cells to every one human cell. Granted, they're quite a bit smaller than us, but I would say we're a big blob of bacteria. We're bacteria, and our chemistry is
But everyone's trying to stay away from bacteria. We have antibacterial soap.
Well, we do overdo the antibacterial problem. I mean, the bacteria on our skin is protecting us from fungal infections and other, there's good and bad strep. There's many things on us, our pH, but those bacteria are actually very protective of us in our stomach and on our outside. And you'll see people, I have one patient that does have OCD. She washes her hands constantly and she's broken out. Her hands are just struggling. And it's not because she's not using lotion. It's because she has no normal flora on her hands. And, everything is
wow.
Opened up, and she's washing off all those emollient oils that we make. Interesting article on vitamin D. When we make vitamin D, which has the ridiculous name of vitamin, it should be a hormone. It is a prohormone. It affects over 60 genetic keys. So vitamin D is very key in mental health because it's also part of transcription, and it is so critically important for the regulation of calcium versus what's in our bones, what's in our bloodstream. The parathyroid uses vitamin D. You can give vitamin D to someone, and if the parathyroid is off axis, it will actually, on many, many people, it will normalize. So hyper or hypocalcemia, very, very important. But in the neurochemistry, vitamin D, and in the immune function, vitamin D is a critical thing. Many, many studies on correlation. They can't say causation, but low vitamin D is correlated with all-cause mortality and morbidity. I mean, it's caused with disease. I don't think it's causing disease, but I feel like it's a very protective thing, vitamin D. So I wish they would name it prohormone D or something else. And I mean, because it is.
But don't you just get vitamin D from the sun?
You would get vitamin D from the sun. We use a lot of sunscreen nowadays. We block about 90% of it. It takes a few, minutes to kind of create it. Some people have vitamin D receptor problems, so they don't receive it well. But in the skin, it's manufactured by UVB rays, which most of our windows filter out. So he gets a little bit of UVA, but not much UVB. I mean, we need to be out in the sun.
With no sunscreen.
With no sunscreen, just for a small amount of time. But then also the article talked about washing it off, like it's made in the oils of the skin, and it takes up to 48 hours to absorb the vitamin D that we created. I mean, ideally the sun would be the best source, and we don't need very much, but we need it on a consistent basis. And we do watch vitamin D levels go down in the winter. We're at a high latitude in Utah. We do not get as much sun. We have a longer winter, and it's absolutely proven that vitamin D levels are lower in the higher latitudes than in the more central regions of the earth. I mean, it's proven. But just taking vitamin D, it's very safe to take a D3, but the correlation and the studies are suggesting that the 30 cutoff for vitamin D levels, the D25 hydroxy, really should be closer to 55 or 60. Finally, in autoimmune, because it's profound effects in immune, people that are specialists in MS and other rheumatoid diseases are starting to look at it saying, hey, you know what, we need to get the vitamin D levels up in these patients to kind of help stabilize some of that, which is so exciting to have.
But this all correlates to mental health.
Absolutely.
The vitamin D, the nutrition, the environment is all correlating back to how I feel.
Absolutely. I mean, just zinc alone, zinc deficiency, massive problems with mood.
There's a lot of talk about medical marijuana and CBD. And it's saying that it helps with anxiety. It's saying that it helps with depression and mood. What is your thoughts on medical marijuana?
And inflammation. There's a lot on the prostaglandins with medical marijuana. With the CBD particularly.
Yes.
So the endocannabinoid system in the human body, it is interesting that we do have those receptors. And breast milk actually has some of the cannabinoid. When we create breast milk, it gets into the baby, and it is very relaxing. And you watch a baby that's breastfed, they just kind of roll off. That little milk is dribbling down their face. You're just like in heaven, you know. But I think CBD is up and coming and going to be incredibly helpful in anxiety. Anxiety is almost worse to deal with than depression for some people. And until you've had an anxiety attack or been highly anxious for hours and hours, you can't understand the enormous stress put on a person. I do believe there's a very chemical component to that. But if there was something much safer than the benzodiazepines, which in Europe they were not going to even take the benzodiazepines on. They found that the studies were not showing great relief. They were very short studies. Yeah, sure, I'm going to feel great if I take a sedative when I'm having an anxiety attack immediately. Alprazolam was touted as, or Xanax, it's just a baby tranquilizer, just a little teeny bit. And yes, it's actually given in 0.025, 0.5, 1, and 2. In substance abuse, the 2 is considered, they call it a bar. 2 milligrams of alprazolam would probably put me out for a day or more. It would be just a massive dose, and I might stop breathing because I'm not habituated to it. But alprazolam, it's gained popularity in its quick action, and it works fabulously for people. Diazepam or Valium is 10 times weaker than alprazolam. And then you've got lorazepam and clonazepam having a more 6 to 8 hour window of mechanism of action. Lorazepam, pretty close to clonazepam, but alprazolam, about 4 hours, 3.5 to 4 hours, close to the opiates. So people are needing to take another one and another one. And I feel like for anxiety, it's the wrong approach just to give a sedative. We need to teach coping mechanisms, do some serious look at the diet. I mean, how much caffeine are these people taking in? The Red Bulls, the energy drinks, they are just wildfire in our society. I mean, I know people who are drinking, 300, 400, 500 milligrams of caffeine. And caffeine's interesting. You only have so much mechanism of action, and then it's becomes kind of inert for the body. I mean, but you still have to clear it.
So is there a proper dose for caffeine if you were to take it?
So caffeine's interesting because it's the most used and abused medicine on the planet. Caffeine is
well, it's in all of our coffee, it's in our tea, it's in our drinks.
Green tea, about 45 milligrams of, caffeine is a lot different than, say, 60 or 120 in an espresso or in these energy drinks. Many people don't look at the energy drinks and say, oh, goodness, there's 4 servings in this can.
But they're taking it because they want to feel good. They're taking it because they're
wanting
their mental health.
Fatigued and that, yes, and it does produce a response. But the problem is it can drive anxiety, and it definitely impacts sleep. And we can't go around the need for sleep in psychiatric. Really good book called Why We Sleep. Excellent, very big and thick. And the man who wrote it, Matthew, his name escapes me. Walker, I believe. Anyway, he is excellent at explaining how he feels that lack of sleep is driving psychiatric disorders as well. So when you sleep, you kind of do clean out the hard drive, get everything ready for the next day, and solidify memories for later on. We know we can induce psychosis by withholding sleep. In the forms of torture, you hear waterboarding and things, but not allowing people to sleep was a definite form of torture. And it was, in the World Health Organization and in other countries, they were going to abandon that form of torture. They weren't going to use it in military zones and using it as a form
of torture.
Yeah,
to get information.
Of getting information. But the U.S. never signed anything that they wouldn't do the sleep deprivation techniques. I can't say that the other countries really abide by that either. I mean, it's war. Always seems to be fair in war.
Yeah.
I mean, it's not exactly a humane process. But if it's so potent to drive psychosis and schizophrenia type symptoms, I mean, how many of Americans are not getting enough sleep or getting very little sleep and just using the energy drink? So I think that's also driving imbalances in neurochemistry. Absolutely, we know that is a big problem. He says there's a stigma with sleep that we think, oh, we only need 6 hours. People need 7.5 to 8 hours, and all the studies continually show that. He's been studying it for 22 years.
And that's for overall health, or is that
That's
just for
overall
normalcy?
health? No, it's for mental health. It's for physiology. 1 week of sleep deprivation changed people's insulin resistance variables, and they used young, healthy students. 1 week started to make them more insulin resistant.
Wow.
And that was profound. And then you get into sleep apnea and those other problems. And I know that there's a whole vein of commercial dentistry now to kind of help with the sleep apnea. I don't know why it's at such a high rise, other than it's also driven by obesity, and obesity is rampant in our country. We're a country of choice. We don't want to be told that we can't have this food or that food, or we're going to eat the portions that we want to eat. But
so what's your opinion on what happened with the food industry? What's your opinion there?
We've kind of abandoned real food. Not abandoned, but there's a big push towards more organic and less toxins, and the neurotoxins they use to kill bugs are neurotoxic to us as well. I mean, pesticides and things have a definite impact on footprint, but at the same time, we've tried to feed the world. We've tried to find sustainable products that will stay on the shelf for years at a time. We can add nutrients. I mean, the nutrientism itself, like just taking a food that has no nutritive value and just adding the nutrients in it. Like just put a multivitamin in the middle of it and it's now a viable food, but you're missing all of those live enzymes that do produce anti-inflammatory effects and things in the body. So our food is highly chemicalized. I think it's studied as much as the pharmaceutical industry for its neuro effects and addiction to certain chemicals. I mean, Diet Coke, it tastes awful when you first drink it, but people love it. They become habituated to it. They are addicted to it. Several of my patients, they'll drink gallons of Diet Coke every day.
Wow.
And at the expense of nutrients that they need as well. And in the energy drinks, let's not forget they put taurine, they put B vitamins. Those are to keep you from having a seizure. I mean, the B vitamins and the taurine, the caffeine at those high levels could induce a seizure.
It's to counteract that.
It's to counteract that. I mean, we're putting, amino acids that calm down the neurons. And it definitely impacts sleep. I mean, and none of the sedatives used for sleep. I mean, sleep is so important, but here we are giving people sleep aids and medications to get them to sleep. That has not been shown in any study to be beneficial.
What about sunrise, sunset?
The circadian rhythm is incredibly important. In Why We Sleep, in that book, he talks about a couple of researchers that went into a cave for 35 days and tracked their circadian rhythm in a cave. And they only had about 15 minutes drift. They stayed on that. So that it's not even just the sunlight. It's also probably where we are on the earth that's dictating it. Could be electromagnetism. Could be other things that also are key signals to the brain. It's time to sleep. It's time to wake up. The suprachiasmatic nucleus, which is in your brain, which gives you that sleep pulse that tells you it's time to sleep, actually kind of degrades as we age. So we start to lose that grip on sleep and wake cycles. And you see that in elderly people.
Well, because they don't sleep very well.
They don't sleep
Elderly
very
don't
well.
sleep.
They don't get that regenerative sleep. Absolutely. And then they're
How can you
awake
help
all
them?
night and asleep all day. Well, there has to be some strict sleep hygiene. There has to be a limit of caffeine. There needs to be exercise. We definitely need to address the psychological stressors that are going on with them and their nutrition. I mean, there are many neurochemicals that you can't even transcribe. Vitamin B6, paroxetine, and P5P is so incredible in neurotranscription. It's in every one of the neurotransmitters pathway. It's in the Krebs cycle, right down to the very, very single cell, how we make energy for our body. We need B6 and B12.
You've shared a lot of information with us. How are you getting all of this information expressed to the patient when you have a 15-minute visit?
I don't think I've ever had a 15-minute visit. My patients are at least a half hour on a follow-up and an hour on a new patient. And I do put some on them to study and learn some of these things. I know that it's far above what they are interested in. Patients that take an interest in their health and really want to feel better, and my patients that have already failed medications, because really some of the medications are maybe 30% effective. That's leaving 70% of people out in the cold going, this didn't work and that didn't work. And I'm always amazed at how many medications they have tried. You cannot discount lifestyle, sleep, nutrition, toxic burden on mental health. You just can't.
Is that where a health coach comes in?
I think a health coach is amazingly important. A health coach, and also someone trained in nutrition, actually trained in nutrition, not trained in nutrition by the American Dietary Association that has, it's funded by the milk industry. It's funded by dairy. It's funded by, cattle and beef. It's funded by grains. I don't believe that there's any bad food for people other than the highly processed, nutrient deficient food. People have to find what's working for them. You can do food allergy tests up and down and you'll find reactivity to something, always. But it's individual. And when you do guide people and help them, it's overwhelming. The information's overwhelming. They cannot wade through it. Drink coffee, it's good for you. Don't drink coffee, it's bad for you. Diet soda is bad for you. Soda is good for you. People are confused.
So how do you personalize and customize a nutrition plan, a health plan, a sleep plan, an exercise plan? How do you customize that to the individual?
I think that does take a multi-team approach. Not one person could be involved.
And that's why it's integrative
I think
health.
That's why it needs to be integrative health. But we do need to treat people, that's why I love primary care, as a hub. We do kind of need to watch these things. I mean, there's beta blockers, for instance, okay? They are a form of blood pressure medication, and they block a beta receptor, so they calm down the blood pressure, and they open up blood vessels, and they work a little bit well. I mean, they change the contractility of the heart, so they lower the blood pressure. Well, it is well known that they block some methylation and some B vitamin transcription. They cause a nutrient deficiency or contribute to it.
We haven't really actually discussed that. I think we need to kind of back up a little bit. Methylation, because my knowledge is methylation is responsible over 150 biochemical responses in the body.
Absolutely.
But what is methylation?
Well, that's where it gets hard to explain. It's a methyl group, which is a chemistry thing that gets put onto another molecule to help either transcribe it or eliminate toxins. It's involved in multiple functions in the body, absolutely. There is checks and balances. So just because you have, say, there's a genetic SNP 677T, which is highly correlated with high homocysteine. You can't break down homocysteine very well without being able to methylate. So homocysteine has been tied to cardiovascular disease. And it was tied back in the 30s and 40s. They found a few genetics, very, very rare. We're saying one in, 10,000 people or less had this genetic disorder, or this inability to make methyltransferase. So this was like, the first person they found was, he was like 13 or 11. He was young boy, and he had a full-on heart attack, and his homocysteine was off the charts. And so we do know that homocysteine acts as a very caustic chemical in the blood vessels and contributes to atherosclerosis or plaquing of the arteries.
Is that inflammation-based?
It's partially inflammation-based, and it drives inflammation. So homocysteine was interesting. They were looking at it, and they were like, oh, then they abandoned homocysteine and went right to the theory of fats and fatty acids being bad for us. And it's the fats that plaque our vessels. But we know now that it's more of a multifactorial. There's very much involved in inflammation. But then there was a little girl that went through the ER, I think she was 8 or 9, full-on heart attack, full occlusion. You know, it was just insane. This is a little girl. And her mom says, oh, her uncle died of this. And they were related. You know, it was her uncle that was the first case where they really looked at homocysteine. This is way back in the 50s and 60s. You know, this is before we went into fat theory. So that's the other problem with dietary. We were told not to eat fat, to eat fat. No, don't eat sugar, do eat sugar. Don't. And it's so confusing that to keep up with the science, we do need a health coach or someone who is putting in the hours and time to look at that. Absolutely. But homocysteine, methylation affects homocysteine getting upregulated. But again, there's 2 pathways. There's actually, I think, 6 or 7 pathways that affect methylation. So we've only focused on 2 in genetic SNPs. So we can't, you know, in the literature, we can't really say this is driving all disease. It is very important, and it seems to be an easy one to fix because you add in the folic acid, not folic acid, but folate. Folic acid is actually kind of harsh on the system. It's synthetic, and it uses the methyl groups, those precious methyl groups that we're not able to make to synthesize it. So folate and 5-quatertetromethylfolate is a little bit safer for those people who have that specific genetic. But I mean, it does make a difference, absolutely. My husband has, his sister had a full descending artery blockage at age 47, which was bizarre to me for a woman to have cardiac disease to that extent. But they do have that methylation genetic pathway block. She happens to have 2 of them, and he has 2 of them, but in a different pathway. I just find it interesting that his brother had a quad bypass, his brother, at age 48, 49. His sister, his other brother has been having heart issues that they're looking at. He's the only one who hasn't had a problem yet, but I've been feeding him methylation support for the last several years. It doesn't mean he doesn't have arterial plaquage here and there, but it's definitely, I'm hoping, attenuating a little bit of that. But it does tend to run in families, and I was very surprised to find it coming through his mother's genetics, not his, because his sister has a different one than him, but his mother has the 677 TT, which is considered the most down-regulatory. They methylate it like 30% or 15%.
I have that as well.
Yeah,
and double.
And his grandson has it as well. So it had to come through his mother to him, to his son, to his grandson. Very interesting because I don't have it.
Oh.
So I was excited.
That is interesting.
I have a 1298C, one of them, but it's not as effective to the system as the 677.
Well, how do people find you, Diane?
So my company's in Midvale. I am, 6770 South, 900 East. It's in a big building, Suite 100. Working on getting the Google page and those things to work properly. When I first created my website, which was pretty rudimentary, I made it on one website and then transferred it to another. So I bought my domain on one and then transferred it. And I think sometimes it comes up, this is an unsafe site because it's being transferred. So I need to get some technical help in there to fix that. But you can find me. I'm paneled with insurance with Blue Cross Blue Shield, not with United. So I'm on some of their databases. I've had mostly word of mouth with my clients or people I've treated before.
So I want to end. I want to end
that have
this.
been pleased with their outcomes.
Yeah, I want to end this of bridging the gap between conventional and functional medicine, because you really said to me, once you study functional medicine, you cannot go back to conventional medicine. But the reason for that is,
I really enjoy looking at the cause, like the root cause of a disorder and its interplay with the rest of the body systems. I was trained, here's a symptom, here's a disease state, here's a med. Very little in lifestyle medicine, but its impact is shown over and over in studies to be the most effective. To start with that, I did have one doctor tell me, they're not going to do those lifestyle things. Your patients aren't going to do that with diabetes. But they do when they understand it. In a 7-minute appointment with a physician, you do not have time to be taught any reason for taking one thing or doing another. And it does become a mill, and I just can't do that, where they come in, you're only allowed to discuss one problem. Nope, your hypertension, here's your med, and you're out the door. Your constipation, here's your med, and you're out the door. I mean, there are medications for constipation, there are medications for headaches, there are medications for IBS, but they don't fix the problem. They might be an antispasmodic. So I can't look at it as a one size fits all, and just learning how these things work and having things opened up to me, like the use of hormones in mood disorders, and I'm very, very conservative on my use of even hormones. I mean, nothing is benign. But I feel like if the woman's deficit actually is estrogen, why am I going to give her an SSRI? There is no SSRI deficit. If serotonin is modulated by estrogen, which we know it is, a little bit of estrogen with its downstream effects. I mean, a bioidentical estrogen, I'm not talking about estrone or Premarin or those things that were pharmaceutically synthetic or not human per se, that had a lot of, the problem with Premarin was a lot of estrone. That E1, that estrogen, estrone is the strongest of them, and it does drive tissue proliferation. And I'm not saying it causes cancer, but it definitely could contribute. But if we can give something that works for her and is safe and isn't going to cause giant mood swings or backlash of anxiety, some SSRIs cause anxiety as those changes are going on, I'm much more interested in that. I do think that there are alternatives for everything, even hypertension. I mean, their weight loss is huge. You can lose 10 points on the systolic by weight loss. Getting enough sleep will lower hypertension. Giving the nutrients you need, managing homocysteine. It just opens up a whole new world. You can't go back to one pill, fix this. And then if you are on one pill and it has a side effect, add a second pill, and then add a third pill, and then add a fourth pill. The polypharmacy is, I see it. I worked in geriatrics for years. People were on 7 to 10 meds all the time. The bane of my day was going into these people's homes and listing all their medications, often given by 3 to 4 different prescribers who I know are not aware
that they were taking all of these other
medications. And then we try to put the pharmacist in charge. Okay, you better catch that interaction. And then we try to put the nurse in charge. Well, if the prescriber makes a mistake and the pharmacist doesn't catch it, and it gets down to you as the nurse and you don't catch it, well, you're liable. And it has become that way, and it's very litigious. But there's no way. Even my pharmacist will say, oh my goodness. I mean, they can run it through a program and say, oh, we think there's interaction. But every physiology is different. You don't know what's going to happen. So wow. It's rampant. But people are willing to make lifestyle changes. People are willing to look at their nutrition. People want to know, what their aluminum load might be, because it is also a neurotoxin. It's in all our deodorant. People want to know these things, and they want to know how to take care of it. And the good news is that a healthy, clean diet and lifestyle do help and attenuate a lot of these problems. It's not knowing that is causing issues as well. I mean, you can definitely
I didn't know any of this. I'm still learning. Every day I'm learning. I had no idea that lithium, which is organic lithium, which we use, has any effect on a vitamin D receptor or on vitamin D. I had no idea, because lithium to me was a psychiatric med, but yet we can use it in low dosing, lithium orotate, and it works fabulously as a tag on with another med, low dosed. So there's just so much more out there. Okay. I have one more question for you. Medical marijuana and even CBD have been shown to actually reduce addiction. And you've been in addiction, and you've treated a lot of
in addiction we do not use medical marijuana at all. I mean, it is a heavy screening. Kratom is frowned upon, which is another psychoactive. Some people say kratom works well for them for pain.
But is it considered a gateway drug? A lot of people think it's a gateway drug.
So that is a conundrum there. Definitely, you can be habituated to marijuana just like many other things. I think a lot of people are trying to deal with anxiety. The problem with marijuana has been over the years it's been hybridized, and the THC is not balanced with the CBD anymore.
No,
So
no.
it can actually drive an anxiety response. And some of the resins, not quite sure. I've had a few patients have seizures on those, using those the first time, and you're thinking, but it's supposed to be anti-seizure. Well, that's THC. That's much different. So the plant itself was balanced in nature as, the psycho
Would just
driver,
genetically
and
modify it.
then the CBD, which is the rate limiter, the calming section that does hit the endocannabinoid system, that kind of gives it that calming effect. They've been using Marinol for years, which is part of THC, to upregulate appetite in cancer patients and other people. I would like to see it studied, but not pharmaceuticalized to the point where it's not affordable for people.
Well, because I know there's a company, GW Pharmaceutical, and they just released a product called Epidiolex, and so they're trying to make cannabis a pharmaceutical.
Yes, they're trying to patent it as a pharmaceutical, but remember, you cannot patent something that's found in nature. You have to change the molecule somewhat in order to patent it and make it your own. Now, you can have manufacturing processes or extraction that's proprietary and things like that. But as far as making a botanical, patenting it, that is not a case. So I'm afraid that we will extract certain parts of the plant, not realizing that the other parts of the plant are also working.
There's lots of research still to be done.
Absolutely. And just taking it as a Schedule 1 drug is a terrible approach. And also labeling people who might be using marijuana as drug addicts, which may not be the case. I have found there are some studies showing that might downregulate proliferation of cancer cells. And actually the THC is part of that. So if we could really look at it, it's just anything that involves money. People want their piece of the pie. And even people I know who are using it for pain, and it does work for many people for chronic pain. It did not work for acute pain, like you have your knee replacement, you're going to use marijuana instead of an opiate or something. It didn't work well for acute pain. But for chronic pain, and it may be some of the psychedelic effects that actually help people kind of relax, which is what we get addicted to in the opiates as well.
Okay.
So they do help for pain, but they also have this psychological effect that helps people relax. I mean, you cannot relax when you're in pain. I've broken my ribs. You cannot relax. And it's a good 10 weeks of pain in every position, and it's always there. And I do feel for these people. But if we make it so expensive that the common person can't afford it, well, why aren't they going to grow it in their backyard and get their own, or use what they can? I mean, that it opens the doors for a more illicit distribution. And so,
what's your thoughts on recreational?
I'm not a big fan of recreational marijuana. I'm not a fan of really any psychoactive that you could, potentially harm your life or your drive or your ability to function or go to work and be a productive member of society. But I'm not a fan of alcohol, and alcohol is very legal. So I haven't seen people go through withdrawal when stopping cannabis per se, like I have with alcohol. And yet that is legal. And we did try to abolish alcohol. I mean, we had a huge alcoholism problem in the past. So we tried, and prohibition was great. It created an amazing cartel of liquor distributors and maybe a little bit of a mafia situation, if you look through that. So I would hate to see that happening. And that is the same with marijuana or any drug. Heroin, any drug that is deemed against the law or is frowned upon is going to have an illicit side. It's going to have...
Sure.
And that's where I think they're the most afraid, not being able to manage people, saying, oh, well, is this prescribed to them or is this illicit? I mean, and also, I mean, you can see our government saying, well, we want to get our taxes on it too. It's a product. And I don't think people pay taxes on illicitly used drugs.
Oh, yeah.
So, and that money has to go back to feed the problems caused by the drugs as well. I mean, we need research.
What about for the families that have somebody addicted in their family? What's the best advice for the families?
Definitely, addiction is not a transient episode. It is a lifelong battle, and I would really encourage them to get with a good addictionologist. And there are some holistic addiction treatment centers. It's harder to find. The family needs treatment as well as the patient. And it is very taxing, and I feel for these people. I mean, this is their child, or this is their husband, or, you know.
I had a nephew, or a cousin, and he passed away because he was addicted to a variety of different drugs, specifically OxyContin, and it took his life. And then it devastated his mother, who was my aunt.
Yeah.
And I just look at what it did to the family, and for the people that actually reached out to him to try to help him with his addictions, and how hard it was on their own mental health.
Absolutely. So the whole family needs to be involved. You definitely need trained, skilled professionals. There's almost always a trauma or some psychiatric issue going on. It's always with addiction. It's either pivot and starts because of the trauma, or the trauma feeds more into the addiction process. Definitely needs to be looked at from a mind, body, spirit approach. I mean, the whole individual.
What if the individual doesn't even he doesn't care that he's addicted, he doesn't want help, but his family wants him to have help?
That is very, very difficult. We have a lot of people come through that are court ordered to be there, or they're only there because they are going to have a consequence to something, a DUI or another criminal charge for them. Hopefully we can kind of get into the system enough with them to kind of help them see that thinking error, or that dead end to that path that they have taken. But it's very skilled. I do not think it's very well treated at home or without professionals involved. You need to find a treatment center, and many times it takes several.
And an admit to a treatment center.
Absolutely. I just don't see it working out very well, trying to detox at home and to go through withdrawals and to deal with the psychiatric changes that go on, stopping those medications. You definitely need a professional involvement there. The problem is it's very expensive, and some insurance doesn't pay for it. And then I think of all my, poorly funded patients.
Well, and all their money has already went to drugs.
Or they've not been proficient. There's a lot of the homeless that are dealing with this, and who's going to pay for that? It is hard. I mean, all of us in addiction, we can give, back to the community. We could do one day a week. I mean, I think it's going to take a huge effort and a lot of people involved. But until you have someone in your family or close to you pass away from that, it will touch every single person in one way or another. Addiction. It's a huge problem in our country, and it always has been an issue. So definitely find someone who is trained in addiction before you try, and inpatient.
Well, thank you,
Seems
Diane.
to be helpful.
Thank you. Really appreciate it.